Assalamu alaikum everyone. Dr. Sayyid, this is Masood here. Today we are going to discuss the medical management of BPH related lower urinary tract symptoms. So the outlines of our discussion would be the pathophysiology of BPH, IPSs and its drawbacks, conservative management, alpha blockers, 5-alpha reductase inhibitors, phosphodiesterase 5 inhibitors, anticholinergic drugs, beta 3 agonists, and phytotherapy. So, pathophysiology of BPH include multiple factors. Where hormonal changes are the primary factor in the development of BPH. Hormonal imbalance, particularly an increase in the dihydrotestosterone, which promotes the growth of the prostate cells. So the prostatic growth also is a contributing factor. Dihydrotestosterone stimulates the prostate cells to multiply and leads to the overgrowth of the glandular tissue within the prostate. This increase in the number of cells, which is called hyperplasia, is a key characteristic of the BPH. Smooth muscle contraction. The prostate surrounds the urethra, and as it enlarges in the BPH, it can compress and constrict the urethra. This can lead to lower urinary tract symptoms because it obstructs the normal flow of urine. So here is a normal physiology of the release of corticosteroids within the body. The hypothalamus gives signals to the pituitary glands to release LH and ACTH. The LH induces Leydig cells of the testes to release testosterone, while the ACTH acts on the adrenal glands, which produces adrenal androgens, and these adrenal androgens acts on the peripheral cells, adipose tissues, and muscles to produce testosterone. When this testosterone comes into the circulation, this goes towards the testes, and within the testes, on the testicular cells, the testosterone binds to 5-alpha reductase. So this 5-alpha reductase isoenzymes converts this testosterone into dihydrotestosterone. This dihydrotestosterone within the within the nucleus binds towards the androgen receptors. So this complex leads towards the DNA proliferations. So this DNA replication gives rise to the hyperplasia of the prostate. So the other factors which gives rise towards the BPH is inflammation. This chronic inflammation in the prostate will contribute towards the development of BPH. So age is strongly associated, and there is a risk of developing of BPH with increasing age. So can anybody tell the correlation of age with the development of BPH? Anybody?
Are there anybody? Because I can't see anyone on the screen. How many people are sitting in Karachi Center?
So now you can see, sir.
Only two. So it is useless to discuss anything.
Okay,
Just
sir.
read the slides and complete your task.
Okay, sir. So there is evidence that the genetic predisposition also plays an important role in the development of BPH. So this pictorial representation describes the development of hyperplasia within the prostate. As you can see here, this is the normal prostate, and urine can pass through the prostatic urethra easily. While there is proliferation within the prostatic cells, leads towards the hyperplasia. So the enlarged prostate would not allow the passage of urine through the prostatic urethra, which leads towards the bladder outlet obstruction. So the IPSS, that is International Prostate Symptom Scores. So in the previous lecture, we have discussed the IPSS scoring system thoroughly, which was described by Dr. Abdul Qayyum and Dr. Mazahir. So I won't take so much time over it. So can anybody tell the so so I will discuss the drawbacks of the IPSS. So there are some drawbacks which restrict the application of the IPSS in general. So one drawback is the subjectivity. The IPSS relies on the patient's self-reporting of their symptoms, as patient has to fill the form himself, so which can be subjective and influenced by the individual perception and interpretation. So there is lack of specificity. So IPSS does not provide a definitive diagnosis and may not differentiate between various underlying causes of the urinary symptoms, such as BPH, urinary tract infections, or other medical conditions. So there is an other drawback, which is scoring variability. So scoring the IPSS may be different between the healthcare providers even. So someone will calculate some other score and the other person will calculate a different score. So it can vary, and so the variation will also leads towards the different modes of treatment availability for the patients on part of the healthcare providers. So incomplete assessment is also a drawback of the IPSS. The IPSS may not address all relevant aspects of a patient's condition, and the additional tests or evaluations may be required for a complete diagnosis. So there is cultural and language bias. The questionnaires, questions, and response options may not be suitable for all cultures or languages, potentially leading towards the misinterpretation of symptoms, as we can often encounter this thing in the OPD 14 prostate clinic. So there is another, the last one, lack of objectivity. So IPSS does not incorporate objective measures such as imaging, laboratory tests to confirm the presence or the severity of BPH or related conditions. So now we will discuss the management of BPH. So the management of BPH can broadly be categorized into the conservative management, the pharmacotherapy, and then the surgical management. So the conservative management includes the watchful waiting. Watchful waiting is a well-known approach to treat the BPH, where men are asymptomatic or with mild to moderate symptoms without causing serious health issues. It is generally considered as the first tier in the therapeutic cascade, and the patients are monitored without receiving any active intervention. So, however, the untreated BPH will progress towards the acute urinary retention and other complications such as renal insufficiency and stones. So we can also advise the lifestyle modifications to the patients who opt non-pharmacological therapy. So weight reduction is an important factor. Exercise and avoiding constipation are also important factors. So the fluid intake adjustment can reduces the storage symptoms. So reduction in the intake of fluids which contains caffeine, alcohol, artificial sweeteners, and carbonated drinks. So especially the evening time intake of the fluids, if we reduce them, there is reduced nocturia. So one of the important factor is urethral milking. If patient is having post-void dribbling, and it can be decreased by urethral milking. Now we will discuss the pharmacotherapy of the BPH. So alpha adrenergic receptors blockers. So alpha blockers, these are the first line medical therapy for the lower urinary tract symptoms due to the BPH. The alpha blockers are preferred over 5-alpha reductase inhibitors because the former have faster onset of action as days to weeks and improve symptoms independent of the prostate size. The alpha blockers are preferred for the patients with lower urinary tract voiding symptoms who have small prostate size, and we will assess the response of the alpha blockers after 2 weeks. So there is a broader classification for the alpha blockers. There are non-selective alpha blockers and the selective ones. The non-selective alpha blockers include phenoxybenzamine, phentolamine, and ergotamine. And the selective ones include alpha-1 blockers, which include prazosin, doxazosin, tirazosin, alfuzosin. And the subcategory is alpha-1A blockers, which includes tamsulosin. The alpha 2 blockers include humin. So this diagram shows the alpha receptors distribution within the body. So alpha 1 receptors include the blood vessels, pupils, pylorus, ureteric sphincters, and the prostate, while the alpha 2 receptors are on the presynaptic nerve terminals. So we can also remember the distribution of alpha receptors via this mnemonic, that is alpha 1. 1 O is for blood vessels, and for the neck of the bladder, prostate, stomach, and E for the eye. This will help us to understand the side effects of the alpha blockers. So if we remember the distribution of the alpha receptors, so we will easily be understanding the side effects of alpha blockers. So the mechanism of action of alpha blockers. The alpha blockers reduce the dynamic factor causing BPH symptoms. So these drugs competitively antagonize alpha adrenergic receptors, thereby causing relaxation of the bladder neck, prostatic urethra, and the prostatic smooth muscles. There is a secondary mechanism of action that includes the alpha blockers induce the prostatic apoptosis, which suggests that these agents may cause some shrinkage of the enlarged prostate as well. So this diagram represents the alpha 1 adrenergic receptors in the lower urinary tract and site of action of alpha adrenergic receptor blockers. So here you can see the bladder neck, the prostatic urethra, and the prostate. So the adverse effects, as I already described, the distribution of the alpha receptors. So here we can see the alpha blockers may result into the drop in the BPH, dizziness, or the fainting, that is orthostatic hypertension, fatigue, nasal congestion, and abnormal ejaculation. So one of the important alpha blocker is prazosin. There is less tachycardia with the prazosin as it lacks alpha 2 receptor blocking action, decrease the cardiac preload, and it suppresses sympathetic outflow from the CNS. It is the potent inhibitor of cyclic phosphodiesterase, causing a rise in the cyclic AMP. This causes rise in the HDL and decrease in the LDL and triglycerides as well. There is relaxation of the smooth muscles in the bladder neck, prostatic urethra, which improves the urine outflow in the BPH. So the adverse effects includes the impotence, nasal congestion, GI tract upset, sodium and water retention. So the alfuzosin, there is another alpha blocker. It is orally effective, and the contraindication is it should be avoided in the patients with hepatic impairment. So sildosin, it is another one which is used to treat signs and symptoms of an enlarged prostate gland. Sildosin is a selective alpha-1 antagonist. Smooth muscle tone in the prostate is mediated by alpha-1 receptors. So blocking them leads towards the relaxation of the smooth muscle in bladder, neck, and prostate, which causes an improvement of the urine flow and decrease in the symptoms of BPH. So tamsulosin, it is widely used as well as at our institution. So it is uroselective, selective alpha-1 adrenergic receptors antagonist, which is primarily located on the bladder, neck, and urethra. So there, its action which leads towards the relaxation of the smooth muscles of the prostate. So it is more selective, and it has better bioavailability than the prazosin. So the adverse effects includes abnormal ejaculation, and the most important adverse effect, which is widely mentioned within the literature, is intraoperative fallopian iris syndrome during the cataract surgery. So the other agent which we can use for the BPH treatment is 5-alpha reductase inhibitors. The 5-alpha reductase inhibitors, they reduce the conversion of testosterone to dihydrotestosterone in the stromal cells, which results in the shrinkage of the prostate by approximately 20 to 25% after 6 months. So it takes long to act. So there are two subtypes of 5-alpha reductase inhibitors, type 1 and type 2, present in the prostate. The majority is the type 2 isoenzymes. So finasteride is a selective type of type 2 isoenzyme inhibitors, and dutasteride is a non-selective inhibitor of both type 1 and type 2 isoenzymes. So when we compare both of these agents, the finasteride and dutasteride, the dutasteride produces faster and more complete inhibition of 5-alpha reductase in the prostate cells. However, there were no difference in the clinical efficacy or adverse effects has been demonstrated between the two agents. So 5-alpha reductase inhibitors have delayed onset of action. They are most effective in the patient with moderate low urinary tract symptoms and larger size of the prostate gland, that is more than 30 gram. So 5-alpha reductase inhibitors reduce the clinical progression of the BPH, specifically the risk of developing urinary retention and need for the surgical intervention. So 5-alpha reductase inhibitors, they work by causing apoptosis of the prostatic epithelial cells, leading to the reduction in the prostate volume and serum PSA levels by 50% after 6 to 12 months. So the minimum of 6 months are required to evaluate the effectiveness of this treatment. So this is the main disadvantage in using 5-alpha reductase inhibitors in patients with moderate to severe symptoms, as it will take long to determine whether the drug is effective or not. So unlike alpha blockers, the 5-alpha reductase inhibitors are used to prevent BPH-related complication and decrease the disease progression. So finasteride has been shown to reduce both the incidence of acute urinary retention by 57% and the need for prostate surgery by 55% in patients with significantly enlarged prostate, that is greater than 40 gram. So the adverse effects of the 5-alpha reductase inhibitors includes the decreased libido and erectile dysfunction, ejaculation disorders, gynecomastia, and the breast tenderness. There would be mood changes, which leads towards the depression and anxiety. Allergic reaction, which includes rash, itching, and swelling. So now the combination therapy. So there is a significant role for the combination therapy in the treatment of BPH. The scientific rationale for combining 5-alpha reductase inhibitors and alpha 1 receptor antagonists is based on their different and complementary modes of action that help in managing static and dynamic component of the BPH, which are responsible for an enlarged prostate gland and symptoms of the lower urinary tract symptoms. So there are some studies, the Veterans Affairs Cooperative Studies and the Prospective European Doxazosin Group evaluated the combination of finasteride with terazosin and doxazosin, respectively, for the 1 year. There was significant improvement in the symptom score, and the flow rate was observed with the alpha 1 adrenergic receptor antagonist alone or combination therapy as compared to the placebo or the finasteride alone. But there was no significant difference observed for the combination therapy or alpha 1 adrenergic receptor antagonist alone. So the cost-effective studies for the combination therapy was done by Nikhil, which suggested that the combination therapy is more suitable for men at high risk for BPH progression. The patients with high symptom score, larger prostate volume, and low Qmax value. The third most important agent is 5-phosphodiesterase inhibitors. The 5-phosphodiesterase inhibitors may be prescribed alone or along with alpha blockers or 5-alpha reductase inhibitors. The 5-phosphodiesterase inhibitors inhibits the proliferation and contraction of the prostatic smooth muscle or enhance the action of nitric oxide. It does not increase the urinary flow rate or reduce the post-void residue. Tadalafil is only for the lower urinary tract symptoms. So their adverse effects includes headache, dizziness, dyspepsia, back pain, and myalgia. The contraindication to them is it should be avoided in patients who are taking nitrites, patients with unstable angina, and those who have persistent hypertension or poorly controlled hypertension. Moreover, the patients who had MI within past 2 weeks, they should be avoided in those patients. Priapism is also a contraindication to their use. Individuals with a history of priapism should use phosphodiesterase 5 inhibitors with caution. So there are some rules for the anticholinergic drugs in the management of BPH-related lower urinary tract symptoms. So anticholinergic drugs are those which antagonize the effect of neurotransmitter acetylcholine in the CNS, which is exerted through the muscarinic receptors. Though they are nicotinic antagonists also block certain actions of the acetylcholine, they are preferred to as a ganglion blockers and neuromuscular blockers. So the muscarinic receptor sites includes heart, salivary glands, smooth muscle of the gastrointestinal tract, genitourinary tract, and the urinary bladder. So this distribution will help us to understand the side effects of the muscarinic antagonists. So the muscarinic antagonist or the anticholinergic drugs includes oxybutynin, flevoxate, dariphenacin, tolterodine, and solifenacin. Flevoxate the mechanism of its action is that the muscarinic antagonist and spasmolytic relief of the condition associated with lack of muscle control in the bladder, such as dysuria, urgency, and nocturia. The indication of it is indicated in urgency, frequency, nocturia, which are the storage symptoms, and the suprapubic pain and incontinence. So the adverse effects of the muscarinic antagonist is the dry mouth, constipation, stomach pain, vomiting, dry eyes, and blurred vision. And it's because of the distribution of muscarinic receptors in all over the body. So dariphenacin, it is selectively antagonizes the M3 receptors, which involve the contraction of bladder, GIT smooth muscles, and saliva production and iris sphincter functions. So their adverse effects will also include the dry mouth, constipation, stomach pain, vomiting, dry eyes, and blurred vision. The most important muscarinic antagonist which we often use is oxybutynin. There is indication, which is symptomatic treatment for overactive bladder, which causes urinary incontinence, frequency, and urgency. So oxybutynin acts to relax the bladder by muscarinic action of.
And move to beta 3 agonist and then conclude.
Yes, sir.
Beta 3 agonist पे आ जाओ और फिर conclude करो.
Okay, sir. So the beta 3 agonists, the mechanism of their action is that the beta 3 agonists activates the beta 3 receptors, which leads towards the relaxation of detrusal muscle, which helps to increase the bladder capacity and reduce the urgency to urinate. This is particularly important in the treatment of overactive bladder. The medical uses of beta 3 agonists in the urinary bladder, obesity and diabetes, and cardiovascular disease. So mirabegron, it is selective beta 3 androgen receptor agonist for the treatment of overactive bladder syndrome. By stimulation of the beta 3 androgen receptors, the contraction of the smooth muscle of bladder is decreased, and the bladder can store more volume at a given time. So this diagram helps towards the mechanism of action of antimuscarinics and beta 3 receptor agonists. So the beta 3 receptor agonist causes detrusor muscle relaxation, increased bladder capacity, and they do not interfere.
चलो चलो पेशेंट लोग क्या थे स्टूडेंट नहीं पढ़ना चाह रहे पेशेंट पढ़ना चाह रहे आगे बढ़
They do not interfere with the voiding process, and the receptors localize to the bladder, so there is no risk for the cognitive impairment. And the antimuscarinic distribution, the antimuscarinic receptor block, the antimuscarinic blockers that they prohibit the distributional muscle contraction, and receptors are located throughout the body. So the beta 3 agonist adverse effects includes the hypertension, nasopharyngitis, urinary tract infections, headache, constipation, upper respiratory infection, and the arthralgia. So the phytotherapy is also important in the treatment of BPH, although there is no scientific significance of it, but it is widely used. The use of phytotherapy for the treatment of LUTS has greatly been increased worldwide since last two decades. The phytotherapy was the second most commonly prescribed therapy, that is 23.5% after alpha 1 blockers, that is 62.5%. So there is a phytotherapeutic agent, that is Serinova repens. It is difficult to pronounce. Sal palmetto berry. The extract of the berry of American dwarf palm. It is most popular and widely studied phytotherapeutic agent for the treatment of LUTS. The previous studies meta-analysis suggested the similar efficacy to the 5 alpha reductase inhibitors in terms of improvement in the symptoms and flow rate. So the more recent studies have generally failed to confirm the clinical important role for saw palmetto in the management of BPH. The NICE in the UK does not recommend phytotherapy for low urinary tract symptoms in the men. Similarly, in USA, the phytotherapy is no longer recommended by the American Urological Association of BPH guidelines. So there are some recommendations of European Association of Urology for medical management of the conservative management of BPH related lower urinary tract symptoms. So the conservative management, we should offer men with mild or moderate symptoms, with who are minimally bothered by their symptoms, and watchful waiting. So it has strong strength rating. We should offer men with low urinary tract symptoms lifestyle advice and self-care information prior to or concurrent with treatment. It also has a stronger strength. So the pharmacological management include the offer. We should offer alpha 1 blockers to men with moderate to severe low urinary tract symptoms. It has strong strength rating. The usage of 5 alpha reductase inhibitors in men who have moderate to severe low urinary tract symptoms and an increased risk of disease progression. That is, the prostatic volume is more than 40 ml. So it is also has strong strength rating. So we should counsel patients about the slow onset of 5 alpha reductase inhibitors. It has a strong strength rating. The use of muscarinic antagonist receptors, muscarinic receptor antagonists in men with moderate to severe LUTS who mainly have bladder storage symptoms. It has also strong strength rating. We do not use antimuscarinic overactive bladder medications in men with a post-void residual volume of more than 150 ml. It has weaker strength. The use of beta 3 agonists in men with moderate to severe LUTS who minimally have bladder storage symptoms. It also has weak strength. So the use of phosphodiesterase type 5 inhibitors in men with moderate to severe LUTS with or without erectile dysfunction. It has a strong strength, and we should offer hexane extracted Serinova repens to men with lower urinary tract symptoms who want to avoid any potential adverse effects, especially related to sexual function. It has weaker strength. We should inform the patient that the magnitude of the efficacy may be modest. It is stronger strength. We should offer combination treatment with an alpha blocker and a 5 alpha reductase inhibitors to men with moderate to severe lower urinary tract symptoms and an increased risk of disease progression. I think we should. So there is an algorithm for the treatment of male low urinary tract symptoms, which has been adopted from European Association of Urology.
Thank you so much, Asad.